Please welcome all with me Dr. Omar, and hope to enjoy his lecture today. Regarding the panel, I am very, very pleased and honored to be one of them. I really appreciate very much all of them. Professor Ahmed Abdelrahman, Professor Khaled Merdad, Professor Edmond. It was very nice to meet all of you today, and hope we will have a very rich webinar from Dr. Omar. So please, Dr. Omar, go ahead.
Thank you, Dr. Hassan. It's my pleasure and honor to be with you all today. And we are here in Minnesota. We are very proud of you, Dr. Hassan, being one of our alumni at the University of Minnesota and one of the endodontic pioneers in the Middle East. And of course, as well as all the other panelists, Dr. Khaled, Dr. Ahmed, Dr. Edmond. It's really a pleasure and honor to be with you all today. And I guess I will start by sharing my screen to start the presentation. And after we're done with the presentation, Dr. Hassan will attend to the questions, and we can start the discussion with the panelists. So I'm sure we will we'll have a fruitful discussion afterwards. So today we're going to talk about a hot topic in dentistry nowadays, which is root resorption. And that's because in modern dentistry, we're saving a lot more of natural teeth. These natural teeth, they stay longer in service, and they are more prone to these defects or root resorption generally. So this is more of a clinically oriented presentation, and hopefully we can all share our experiences with this hot topic. So first of all, when we talk about root resorption by definition, and it's very important to know that sometimes it's a physiological condition, it's not always pathological, leading to the loss of tooth structure, whether dentin, cementum, and or bone. And that definition is the definition that's published in the AAE Glossary of Endodontic Terms. And I hereby invite you all to download this valuable resource. It's free of charge, it's available online. You can just Google it and you can download it. Provides you with definitions for a lot of terms that we use in endodontics. So first of all, root resorption, what are the causative factors that are causing this process to happen? And there are two main factors that are involved. It's either a bacterial infection or an inflammation that's going on within or around the tooth structure. And those factors are influenced by trauma, which is a very notorious factor for initiating the resorptive process. We have bleaching, we have pressure, and that's the term that my friends and colleagues in orthodontics like to use, because orthodontics in its per se, it's not the cause of root resorption. It's just the undue pressure. When you put a lot of pressure on teeth, you can initiate root resorption. And also there are some idiopathic causes, which we will try to dive into these factors later in this presentation too. And again, as we discussed earlier, it's going to be a more clinical presentation. I'm not going to dive deeply into the histopathology of root resorption, but just a brief discussion about the mechanism of root resorption. Basically, you need to have an absence of a protective layer, which is the pre-cementum on the external surface of the tooth, or pre-dentin if the inflammation or the infection is happening within the pulp. And with that comes a lot of humoral responses, mainly, there is a disturbance in the balance between osteoprotegerin and receptor activator of the nuclear factor. So again, I'm not gonna dive into the histopathology, but all these humoral responses can cause the activation of the clastic cells, their differentiation, and initiating the resorptive process. And if we want to talk further about the classification, which is very important for us as clinicians to be able to diagnose what's going on with the resorptive process. So the classification, there are four main categories of root resorption that we can deal with. Number one is surface resorption. Two is replacement resorption, or the more clinical term, ankylosis. The third is inflammatory resorption, and the fourth, which is a distinct classification from the inflammatory category, which is the invasive cervical resorption. And during this presentation, we'll dive into all these four classifications. So first, the surface resorption, and from its name, it happens on a surface. And with that, usually it's a trauma to the PDL. Usually it happens on the external surface of the root. And usually that kind of resorption is repair driven, meaning that with the resolution of the causative factor, which is the trauma, whether it's an occlusal trauma or a physical trauma to the tooth, usually there is some repair, and the lost dentin is usually replaced by cementum and PDL. And with that, it becomes a very tricky how to deal with surface resorption. And the key here is by doing pulp sensibility testing, taking a good history from the patient about the history of trauma, history of symptoms, and all of that. And in these cases, monitoring is warranted when you have all your testing within normal limits. The second category, which is replacement resorption, as we mentioned earlier, or ankylosis. And with that, the tooth structure is actually replaced by bone. So this time it's not replaced by cementum or PDL. It's actually replaced by bone. And with that, clinically, we all know that the metallic percussion is very notorious in these cases. And with pulp sensibility testing, it differs between one case and another, whether you're dealing with vital pulp or the tooth structure was completely replaced with bone. So there is a notion that ankylosis is self-limiting, and unfortunately that's not true, because ankylosis can be very aggressive, reaching to eat out the whole tooth structure. So we need to keep that in mind. And we're dealing with the replacement resorption comes the question, so when do we treat these ankylosed teeth? So in adults, generally, we don't treat those cases, but it becomes a challenge when we're dealing with these cases in younger patients. And when there is a discrepancy in the occlusal plane of 2 millimeters or more, treatment at this point is warranted. And the goal for treatment at this point is not saving the natural tooth structure per se, it's just saving the bone height and width until the time comes when this tooth can be extracted and replaced. And at this point, the tooth can be just kept for aesthetics for the patient. And how we treat these cases or ankylosed cases when there is a discrepancy in young patients, what we do is called a decoronation procedure. And with the decoronation procedure, we make sure that we remove the clinical crown, and the most important part is removing the supracrestal fibers. Removing the supracrestal fibers will make sure that the tooth get totally submerged in bone, at the same time maintaining bone height and width, but not causing any collapse from the traction forces that the supracrestal fibers can put on the skeletal structure in that area. And after we do the decoronation procedure, again, the tooth is basically embedded in bone until the time comes for implant replacement or bridge replacement, but usually this procedure is indicated in implant placement. And you can see here in this case that it's very important that we have the clinical crown removed. Supracrestal fibers are ensured to be removed by making sure that the tooth is submerged by 2 millimeters in bone. And then you can suture on top of it. You don't really have to put anything in the open tooth. And that's because you'll have a blood clot that's formed inside the tooth. So there is no need for restoration. Now, in cases where you're questioning the sealability of the tissue, or if there is no enough epithelialization in the area, you can attempt to put a plug in there, like a glass ionomer plug in there, so you can make sure that you have an infection-free site. And with the decoronation procedure, after it's done, it's very important that we monitor the area and monitor how the skeletal response is, because after the decoronation, that's what we're looking for, maintaining bone height and width. As you can see here, this is a comparison between a tooth that had a decoronation procedure, and in the lower picture, you can see a tooth that was prematurely extracted You can see the difference definitely in the bone height and width, and all implant specialists will definitely prefer the upper picture compared to the lower one. Now, as we dive deeper into the root resorption in endodontics, so surface and replacement resorption are not very often encountered in comparison to inflammatory resorption. Inflammatory resorption is, I would say, the biggest class or the biggest category of root resorption that we face on a daily basis. And the inflammatory resorption category is further subdivided into internal and external, and from its name, it differs. If the affected structure is the pulp, then it's an internal resorption. And if the affected structure is external or on the PDL, then it's an external root resorption. And with this classification, it's usually progressive and it requires endodontic intervention. So whenever you diagnose an inflammatory resorption, it will need you to start doing root canal treatment. And I would like to highlight what we can see here on these scans with these pictures, that especially with external root resorption, the clastic activity, it's not uniform. And that in itself presents a challenge for proper cleaning and disinfection and obtaining a proper seal for these cases. And this is very important when you discuss the case with your patient. You need to set up their expectations, what they're expecting from treatment. We do our best to try to save natural teeth, but we want to make sure that they know that the prognosis is questionable in these cases, and multiple treatments may be required, meaning that non-surgical and later on surgical intervention may be needed, as we'll see further in this presentation. So with inflammatory resorption, the first part is the external root resorption. And as we said earlier, it affects the external surface of the tooth. And usually with these cases, the pulp is necrotic. So when you do a pulp sensibility testing, you get a negative response. And what happens is the pulp gets necrotic, and then the bacterial toxins are able to penetrate through the dentinal tubules and start causing an infection and an inflammation on the PDL, on the external surface, initiating the resorptive process on the external surface with the absence of the protective layer that we discussed, which is the pre-cementum. And usually it affects not just the tooth structure, it also affects the surrounding bone in the periodontium. And treatment for these cases, it's recommended that you apply calcium hydroxide intracanal medicament for 2 to 4 weeks. And the reason for that suggestion when you do root canals for these cases is that we want to try to arrest the clastic activity by reversing the pH. So we all know that calcium hydroxide is alkaline in nature. So we want to reverse the pH to arrest the clastic activity, and at the same time benefit from its antibacterial action as the calcium hydroxide penetrates through the dentinal tubules. And in these cases, unfortunately, the root canal treatment without the calcium hydroxide, literature have shown that you can have a negative impact, because root canal treatment on its own, sometimes it cannot be successful. As you can see in this case, probably the root canal at the time of treatment was properly done, but the resorptive process didn't arrest or didn't stop. So that's why trying to do our best in these cases, intracanal medication is recommended in these cases. But back to the nature of this resorptive defect, as we discussed earlier, that on the scan you can see that the non-uniform or the irregular shape of the defect, making our ability to seal those defects, sometimes it's difficult. And that's why it's been shown in the endodontic literature that success rates of dealing with these cases, it's not very promising. And that's why we want to make sure that the patient is informed when dealing with these cases. But thanks to modern technology, we're able to treat more of these cases successfully, because in the past, for example, we didn't have cone beam technology, so we're not able to detect when exactly is the termination of the canal part, and because in these cases, the apical constriction is probably destroyed by the infection that's present with the external inflammatory resorption. So here in this case, you can see that the radiographic apex is way more further apical to where you can actually see where the tooth is actually resorbed and is in communication with the periodontium. So in these cases, you get your cone beam measurement, you trust your electronic apex locator measurement, and this is where you actually stop. So it's not always a radiographic presentation on a two-dimensional image where you stop with your treatment. And in this case, the case was actually treated with MTA, and then afterwards the tooth was restored with composite. And this is the post-op, and this is the recall showing the intact apical tissues. So again, this is the tricky part, that whenever you're dealing with external root resorption, my recommendation is always for the patient to get a CBCT image so we can have a proper study of the defect or the resorptive process that's going on with the tooth. The other thing, sometimes you can get cases like this where the root canal treatment looks nicely done. With multiple angulations, of course, you can see the periapical lesion, but you're not seeing any signs of missed canals. You don't have a proper diagnosis of etiology. And you'll be surprised when you take a three-dimensional image, what you can find with these cases. So here again, you can see the root canal looks fine, the crown looks great on the tooth, no signs of coronal leakage with clinical testing. So sure enough, with this case, a 3D scan was taken, and with the axial view here, you can see that there was a resorptive process that's going on. And actually part of that tooth was floating in space, which is something that you cannot really appreciate on a two-dimensional image. In addition to that floating part, you can also appreciate here on the resorptive defect and the amount of infection and probably extra radicular biofilm that has been produced by the infection that's going on. So here comes the question, do I treat these cases from a non-surgical standpoint and go for a retreatment? And the answer is, I go to the endodontic literature that guides us and tells us that success rates dealing with these cases, it's as low as 70% when we're dealing with external resorption. The other thing, there is an additional layer of challenge in these cases because it's previously treated, so that automatically drops the prognosis even more. So in these cases, surgical intervention becomes more predictable. And the reason for that is with the surgical intervention, we're basically eliminating the resorptive defect. We're eliminating the extraradicular biofilm that's present. We can also ensure a good apical seal, which we won't be able to ensure from a non-surgical standpoint, as you can see here with the next video. So this is after root resection. You can see here the sinus membrane is at the back of the osteotomy, but with careful cone beam measurements, we're able to avoid that. Now here with the retro prep, with the use of modern microsurgical techniques, we can retro prep the main canal and we can retro prep the surgical defect as well, ensuring proper cleansing of that area. And then following that, this case was actually sealed with biceramic putty for the main canal and for the resorptive defect as well. And in my opinion, this would provide the patient with a more successful outcome, given the good seal that we can get with the surgical intervention in this case. And this is actually a 2-year recall for this case, and you can appreciate the bone regeneration in the area, the proper seal that we have for the main canal and for the resorptive defect as well. And of course, you can see that there is no further advancement for the defect, and the tooth structure is healthy. Now, with the other part of inflammatory resorption is the internal root resorption, which is a little bit easier to treat, and we'll discuss the reason for that. So with internal root resorption, the pulp sensibility testing, it's usually vital, or within, you get a normal response. And with that, because with internal root resorption, you need to have a source for tissues to try to initiate or maintain the resorptive process from the inside of the tooth. And as we discussed, that internal root resorption is inflammatory in nature, so we need to intervene. And the problem with that is the absence of the predentin. So the clastic cells that are differentiated from the pulp tissue can start harboring the dentin in the surface and then start eating out the tooth structure, basically. And in advanced stages, you can also notice a pink hue or some possible crown discoloration in these cases that are aesthetically unpleasant for patients. And with the reason why we get normal pulp sensibility testing, again, because you need to have source of cellular supply for the clastic cells to start causing its action. So with the internal resorption, you usually have necrotic tissue up to the point of the resorptive defect. And below or apical to the resorptive defect, then you'll have your vital structure, your vital pulp that will provide the cells. So it becomes very difficult to differentiate between, in a clinical scenario, between necrotic and vital. So that's why the whole inflammation needs to be removed, and that's why root canal treatment in these cases is indicated, so we can get rid of the source of clastic cells that are present, although the apical part to the defect is somehow normal pulp. And with internal resorption, the treatment challenge is much easier. With modern endodontics, with the use of different modes of activation for irrigation, with use of thermoplasticized gutta-percha for obturation, we're able to provide a good seal internally without the need for surgical intervention. And that's why for internal resorption, the success rates are much higher compared to external root resorption, and we need to keep that in mind. And it's very successful to the point that as clinicians, sometimes we can encounter internal root resorption without really knowing that we're dealing with one. Like in this case, it's a molar tooth, a C-shaped anatomy, and this C-shaped anatomy was addressed with non-surgical root canal treatment. And everything went well with the treatment, but to my surprise, on the post-op radiograph, I can see that there was some internal resorption that was going on that I couldn't appreciate with pre-op images. Perhaps if I took a Cbct scan, I would be able to see it better. But again, with root canal treatment, not all of the time we take scans for our cases. But the pleasant surprise that you get is if you have all the tools and armamentarium following modern endodontic principles, you'll be able to get good seal with internal resorption cases. But sometimes it's not that black and white. Sometimes there is a gray zone where you have a combined case, where the case is presented with internal and external resorption at the same time. Like in this case, the patient presented with a symptomatic tooth. The crown was just placed recently, and the patient was again having sensitivity to chewing, hot and cold drinks. So at this point, definitely intervention is warranted. But you can see on the periapical radiograph here that we're dealing with some kind of resorption. And here, when it's that obvious on a two-dimensional image, I always opt for a 3D scan. And with the 3D scan here, you can appreciate on the axial view that we were dealing with an internal resorption that already perforated to the lingual aspect of the tooth, causing an external resorption as well. And here comes the challenge that you want to treat it, but at the same time, you want to maintain a good seal. So it's recommended that in these cases, and it depends on the level of the defect. So if you're dealing with a defect that it's sub-bony or inside bone, then you'll be able to use a bioceramic material. It's not recommended to use that material if you're dealing with a supracrestal defect, because these bioceramic materials, they actually lack washout resistance, and they can be easily washed out. So this, since it was an infrabony or sub-bony defect, the treatment was done with gutta-percha for the apical part, and then that was the gutta-percha cone was seared below the level of the defect, and then bioceramic putty was used for the coronal part. And here you can see on the post-op that it looks like we have a good seal, and hoping that this bone loss and defurcation area will be regenerated. And that the key for success in these cases is obtaining a good coronal seal and good seal in the defect as well, in addition to eliminating the causative factors or the tissues that are causing the resorptive process to be initiated. And this is actually a 2-year recall in the case for the case, and you can see here the bone is already regenerated in the furcation area. The patient is asymptomatic. There is no further treatment is warranted for this patient, perhaps maybe changing the existing crown because there are some signs of recurrent caries that are happening around the margin. But other than that, for the tooth or the foundation of the tooth, it looks great. So here it becomes very important again to take Cbct scans to be able to properly diagnose and properly treatment plan for these combined cases where you have internal and external resorption happening at the same time. And from here, it will take us to the last but not the least independent category of resorption, which I would say it somehow it belongs to the inflammatory category, but it happens a lot nowadays that it's now independent and has its own classification, which is the invasive cervical resorption. And from its name, invasive, it's very aggressive, and it usually happens at the cervical level of the tooth. And the affected structure is the PDL. And with that PDL, how it's going to be affected by various types of trauma. And the notion that the type of trauma is usually a physical trauma is not true, because there are some other factors that can cause PDL trauma in the area that we're going to discuss here briefly. But just a quick anatomical look why this process is initiated, and that's because of the CEJ or cemento-enamel junction configuration that can happen. Thankfully, most of the time there is an overlap between cementum and enamel, and that overlap brings a protective layer for the dentin and makes it not easy for the traumatized PDL or the tissues in the PDL to start causing resorption. But the problem comes if we're dealing with an abutting joint or with a gap joint. So a gap, basically the dentin is exposed and clastic cells can start attaching to the dentin through their house-shaped plaques and start eating out the tooth structure. And with the abutting joints, it becomes very difficult because this very thin protective layer here can be easily dislodged, and then the dentin will be exposed. And with this configuration, there is a classification for different grades of invasive cervical resorption by Hethersay. And this classification is very, very important, again, to set up the prognosis for the patients when we're dealing with these cases on a clinical aspect. So according to Hethersay, with this classification, usually class 1 and class 2, we have really high success rates treating these cases, which means that the resorptive defect, it's still within the coronal tooth structure with no radicular extension. With initial radicular extension or class 3, you have a drop in the prognosis, and with more invasive radicular extension or class 4, it becomes very low. So here it becomes the dilemma between class 3 and class 4, when exactly we can save the tooth for the patient. And treating these cases, it needs to be done on highly motivated patients that are willing to save the tooth structure as much as they can. And if we dive into the causative factors for invasive cervical resorption, again, the trauma is not just physical trauma that can happen. There are some other things like bleaching, which can be very aggressive, and we're going to discuss how can we prevent that from happening, but also aggressive scaling and root planing. And we need to keep that in mind, that when we have patients for scaling and root planing, aggressive scaling doesn't mean that you're getting a clean surface. Actually, with aggressive scaling, you're damaging the cementum, you're exposing the dentin, and you make the tooth more prone for a resorptive process. That's why with hygiene visits, we need to make sure that we're being gentle on the tooth while removing the calculus for any deposits on the tooth surface as well. And also, as we discussed earlier, that ortho plays an important role with undue pressure on these teeth. Now, from an endodontic standpoint, what we can control or how can we prevent is because us as endodontists or general dentists with special interest in endodontics, we do internal bleaching a lot. And with internal bleaching, it's very successful. And usually patients, they have really, really pleasant outcomes for them with internal bleaching. But the problem with internal bleaching is that the bleaching agent can penetrate through the dentinal tubules, go all the way to the exposed dentin, and then traumatize the PDL, and then the invasive cervical resorption is initiated. So how we prevent that before doing internal bleaching is that after you obturate the tooth with gutta percha, it's recommended that you put a barrier on top of the gutta percha so you can prevent the bleaching agent from penetrating through the dentinal tubules and start causing problems. But the clinical notion that this barrier is just the base that you put on top of the gutta percha is actually not true. So what you need to do when putting this base on top of the gutta percha is that you want to make sure that you're following the 3D configuration of the cemento-enamel junction. And we all know that it's following the anatomy of the tooth, that it's not just the base, it has some scalloping to it. So that's why the base, or the glass ionomer base that you put on the gutta percha, needs to be saucer shaped so it can follow the configuration of the CEJ and ensure a good seal before you initiate the internal bleaching. The other thing, if you're going to use heat with internal bleaching, it's recommended that it needs to be very minimal. And the other thing, it needs to be intermittent. So you don't put the heat source when you're doing internal bleaching inside the tooth for a long period of time, because that can also affect how the bleaching agents can cause negative effect on the PDL. And with treatment for invasive cervical resorption, in order to get a predictable outcome, in these cases, the number one option that's recommended is surgical intervention. And we're going to discuss non-surgical intervention as well. But the reason why surgical intervention is recommended is the source of the problem, again, is resorptive tissue. And that's in the PDL region, and that needs to be removed or at least arrested. Ensuring the arresting of the clastic activity from the external surface of the tooth via a non-surgical approach can be unpredictable, as we discussed earlier. And that's why with the surgical approach, what we do after we reflect a flap, we make sure that the area is completely clean from any tissue that's present. And from there, you can decide whether it's just going to be the surgery and restore the defect, or if you have a pulp exposure, then you start doing a root canal treatment, of course, because you have a pulp exposure. Or if the patient presented with signs and symptoms that would indicate the need for root canal treatment. And with the restoration of the defect, the material of choice to restore these defects, because it's cervical in nature, it's supracrestal, so glass ionomer or resin modified glass ionomer will be the material of choice, and not a bioceramic material that would wash out in this position. And here, this is a case that was done by one of our residents, Dr. Jeff Heisey. This case presented, as you can see, with a defect here. Now, I get a lot of questions, so how I can differentiate if this is actually caries or if it's a resorptive defect. And the answer for that question is usually two answers, or twofolds for the answer. First of all, you want to cover the caries index for the patient and see whether they're prone for a lot of decay in that area or not. So number one, you make sure that you have a proper caries index for the area. The other thing with these resorptive defects, when you do some probing in the area, it's not mushy or caries tooth structure that you will get on a clinical, in a clinical scenario of caries. Actually, you'll have some tissue that it's occupying that defect, indicating the presence of the resorptive defect in that area. So with this patient, actually, the tooth was symptomatic and root canal treatment was warranted in this case. So in these cases, you have the option whether you want to do surgery first or you want to do a root canal treatment first. I usually prefer to do the root canal treatment first and then follow it up with the surgery so I can do the final cleanup after I do the surgical procedure. So sure enough, with this case, a Cbct scan was taken. You can appreciate here the defect that is in the labial position here, as you can see. And Again, the tooth was symptomatic. That's why root canal treatment was initiated. Calcium hydroxide intracanal medication was used. And then the obturation part for the apical part was gutta percha, and then bidentine was used on top of that. And the tooth was restored. And then the patient comes back for the surgical intervention. Now, with these cases comes also the restorative question: do I put a post in there or not? Now, putting a post in these cases, it might weaken the tooth structure if you start drilling for it. But if you're gonna do passive insertion of a fiber post, that's gonna be perfectly fine. And with the surgical procedure, and this is just a clinical tip, that when you do surgery for these cases, it's always recommended to have a full intrasulcular incision and not depend on any submarginal incision. Because with submarginal incision, you basically can be covering the defect without having enough convenience or enough access to be able to clean the defect from the resorptive tissue. So here you can see the envelope flap that we just need to be able to expose the tissue. And here you can see again, the tissue inside it, it's actually a real tissue. It's not carious tooth structure that we're dealing with at this point. You can see a bulk of tissue that's coming out from the defect. And from there, you can just clean up the area and start the restoration right away. In some of the endodontic literature, it's recommended to use TCA, or trichloroacetic acid. But I want to highlight that this acid is highly caustic and it can cause bone resorption easily. So if you're going to use that, you need to make sure that you're using a block out material in the area, so you avoid the TCA touching any structure beyond the tooth structure. And if you're going to use it, you just need to make sure that it's very concise on the tip of a microbrush to be able to use it, which here what Dr. Heisey did in this case. And in order to ensure that you are removing all the tissue that's present in there, it's also suggested that you use methylene blue stain, because that will be able, you'll be able to see if there are any remnants of tissue, which may cause relapse for the case present or not. And if you see any remnants with methylene blue staining, you can go ahead and remove it with either a burr, or if you want to be a little more conservative, you can opt for ultrasonics to remove the rest after you use the burr for the main bulk of the resorptive defect. And again, this is the blocking out agent. So you make sure if you're going to use TCA, that it's going to be very concise to the area, and it's going to be on the tip of a microbrush, so you don't cause any bone necrosis or tissue necrosis in the area. And here you can see that it's in action, but I want to also highlight that TCA is transparent, so it becomes very difficult to see even with microscope magnification. So that's why I'm not really a big fan of TCA. And in my clinical practice, I deal with these cases usually without the need for TCA application, but I just wanted to highlight that it's there. And if you're interested in using it, you'll have endodontic literature that would support you to do so. And with this case, resin modified glass ionomer was used to seal the defect. And you can see here with the post-op that the tooth is saved with the patient, for the patient. And again, it needs, the patient needs to be highly motivated to save the tooth. And this is actually a more advanced case for invasive cervical resorption. The reason I want to highlight this, because this case is actually more invasive into the radicular structure, and not all the defect is exposed. As you can see here, there is some resorption that's going on that's still covered by intact tooth structure on the external surface of the tooth. And also the destruction, as you can see, is even more on the labial aspect of the tooth, as we can see on the 3D scan. Now, the problem with these cases is, again, the prognosis is much lower than we're dealing with class 1 or class 2, according to Heather say. But with motivated patients, with all the armamentarium that we have, there is a way for success in these cases. However, after doing the root canal treatment, you can see how messy the operation is, and that's why I prefer to do the root canal treatment first, followed by the surgery. Now, the importance when dealing with these cases is that we're not going to clean the resorptive defect that's exposed to us under magnification. We want to make sure that we're tracing and cleaning the area all the way down to the whole extent of the defect, which can be guided by an accurate 3D measurement with the Cbct scan. Also, the CBCT scan can show us where exactly the missing tooth structure is more in one side than the other. So that will help us to proper a good contour for the root so we can enhance the bone regeneration or the periodontal tissue regeneration in that area. The periodontal tissue regeneration so we don't have any overhangs or things that would obstruct the tissue regeneration in this area. And in this case was restored with resin-modified glass ionomer. And you can see that building up the wall here is going to be on the mesial. It's much more challenging because you want to make sure that you build it on the mesial line angle and make sure that you have a good root contour for periodontal regeneration. And of course, as you do any type of restoration, you need to make sure that it's smooth and it's blending with the adjacent tooth structure when you're dealing with this kind of surgery. So you make sure that there are some self-cleansable areas without any overhangs. So you would achieve the endodontic success hand in hand with the periodontal success, which is very important in these cases. And I know this is not an ideal situation. You can see this, it looks ugly on the post-op radiograph because a lot of tooth structure is missed because of that resorptive defect. But again, this was the best that we could do for the patient to save this tooth for them. And if you're dealing with a motivated patient, you can definitely save it. And this tooth is actually in service in the patient mouth for 3 years now. So it's doable and it's successful. We just need to make sure that we're covering the principles when we're dealing with these cases. And with these cases, you can also do non-surgical management if you're not really comfortable with the surgery or if there is a contraindication for surgery. Like in this case, the patient was on bisphosphonate therapy, surgery was contraindicated. So what you do on a 3D scan, it's very important to have, I'm going to skip this slide just to make sure that we have 3 accurate measurements if you're doing it, treating the tooth non-surgically. You're going to measure from the incisal edge to the periphery of the defect and to the full extent of the defect so you can subtract and get the actual distance of the defect. And also you want to see on the CBCT scan what's the nature of the defect. Is it supracrestal or subcrestal? In this case, it's supracrestal. So again, I re-emphasize the point again and again that with these cases, glass ionomer or resin-modified glass ionomer is going to be better than a bioceramic material. So this treatment was initiated with a non-surgical approach. As you can see here, it's a calcium hydroxide intracanal medicament. And the patient came back 2 weeks later for obturation. The apical part is gutta percha. And then I know it's messy and that's why it's unpredictable, but it works from a non-surgical standpoint is I inject the resin-modified glass ionomer to try to somehow seal it internally, although I'm using magnification and illumination of a microscope. But again, this is why it's unpredictable, but it works. If you're not comfortable with surgery, the patient is not uncomfortable with surgery or have any contraindication, it's actually doable. And this is actually a 1-year recall for the patient. The tooth is perfectly fine. The horizontal and the vertical level of the bone is perfectly fine. And it was a successful outcome with a non-surgical approach that you can achieve on a daily basis. The key here, CBCT measurement, knowing where the defect is, and properly addressing and understanding the resorptive process so you can deal with it with a non-surgical standpoint. So finally, I hope with this presentation, I was able to clarify some of the misconceptions about resorption, that resorption is always pathological, and that's not true, because as we discussed earlier with surface resorption, it can be self-limiting, it can be repair-driven. So we need to keep that in mind when we're faced with resorptive cases. The key here is to monitor these patients closely and with regular recalls. So any change in pulp sensibility testing, radiographic findings, or signs and symptoms, then treatment and intervention is warranted if the resorptive process is within the inflammatory range and not within the surface range anymore. The other thing that is always progressive leading to eventual tooth loss, because with modern dentistry, I hope this misconception is cleared, because with modern dentistry, we have a lot of tools, a lot of techniques, surgical and non-surgical, that will help us to maintain those natural teeth in function for a very long time. And the other thing, when you discuss the outcome for the patient, you can never say in a resorptive defect scenario that the treatment is going to guarantee success. Of course, you can't guarantee any type of treatment, but even with resorption, the prognosis is even lower. So that's why you need to set up patient expectations and let them know that non-surgical approach may be needed to be followed up by surgical approach, to be able to get, the key here is proper seal and getting rid of the clastic tissue. And last but not the least, that this type of defect is uncommon, because again, in modern dentistry, we save a lot of natural teeth. A lot of teeth are more in service, and they're more prone to various types of traumas, to the pulp and to the PDL, yielding in these resorptive processes. And finally, I would like to thank you all for attending this presentation. And I'm sure that now we'll have a great discussion with our experts, with our panelists. But I would like to thank you all, and it would be my pleasure to have the input of our esteemed panelists, so we can start that discussion. Thank you.
Well, thank you very much, Dr. Omar. It was excellent and very rich and informative lectures. I really enjoyed personally very much. And I would like to give a chance to our distinguished panel here, starting with Dr. Ahmed Abdelrahman, please.
Dr. Omar, thank you for the interesting lecture. This is what we used from you. And, you know, I just have to ask you a couple of questions.
Sure.
One of them actually about the last case about bisphosphonates. You know, in external cervical root resorption, the source coming from medullary ligament. So actually in you, do you think that this conventional treatment is lasts for a long time because you didn't remove the source of tissue which is responsible for the resorption? Second thing, that you are trying to clean the area from, you know, more constricted area to a more wider area because the resorption is coming from outside. So can you comment on this?
Yes, thank you, Dr. Ahmed. Always a fruitful discussion with you. Those are really great questions. And when I discuss the treatment with the patient, in this case, I tell them, I totally agree with you. I didn't remove the resorptive tissue at all. What I did, I just tried to arrest the clastic activity with calcium hydroxide, and hopefully that would arrest the clastic activity. I'm not 100% sure, and that's why the treatment in itself is unpredictable. But I tell the patient this is the last that I can do, so we can try to save that tooth and not going through the dilemma of doing surgery or extraction for the patient on bisphosphonates. But I definitely agree with you. It's totally unpredictable. And going from a narrow space to a larger space, that also it's another challenge. I'm not really confident about cleaning the space, but it was really an unideal scenario, and I just had to deal with it. But the most that I can do is hoping that the calcium hydroxide will arrest the clastic activity.
Definitely. I agree with you that sometimes we are faced with situations which we have to drop our expectations, go to less than ideal, because this patient has bisphosphonates and they cannot extract the tooth.
Yes.
My second question, you talked about suprabony perforations, and what about combined one? If you have part of the resorption is below the bone level and the other is above the bone level, what do you do in such cases in restoration?
So first of all, I would like to thank you because you are my reference for bioceramic and washout resistance. Your article in the Journal of Endodontics was great, helping us to confirm that the washout resistance for supracrustal defects is not that great. But with combined lesions, it's definitely challenging. And if I'm dealing with a combined case where it's suprabony and suprabony at the same time, I would do bioceramic to the level of the bone, and then still resin modified glass ionomer or glass ionomer for the exposed part. I'm not sure if any bioceramic material, maybe biodentine, can last. There is some literature coming out confirming that biodentine maybe can be a little better than MTA or bioceramic putty that we use regularly. But still, I'm not 100% confident about putting a bioceramic material in a supracrustal level. So I would go for separate layers of restorative materials for both.
Do you consider in some cases using guided tissue regeneration, putting membrane? When you do this?
So with invasive cervical resorption, I typically don't do it because I'm not hoping for bone regeneration. I'm just hoping for the periodontium to get regenerated. If not periodontal ligaments, then at least junctional epithelium, so I can have some sort of attachment to avoid any leakage in that area. But if I am dealing with an apical marginal defect that's affecting the buccal cortical plate of bone, then yes, definitely I would consider guided tissue regeneration and grafting and putting a membrane to address these cases.
Thank you. I have taken a lot of time, so
well, we would like to give the other gentleman.
Yeah.
Dr. Edmond, please.
Oh, thank you. Well, I really appreciate highly the lecture. The quality of the presentation, Dr. Omar, was really overwhelming, and I really appreciate this. And I learned a lot of your presentation. However, I've been treating resorptions a long time ago. You know, I'm old. I have a career of 40 years of
don't say this. Don't say this, please.
Still young in the soul. So, Dr. Omar, speaking about the internal resorptions, I would like to maybe ask you a question about the calcium hydroxide, because I think that the calcium hydroxide will have a positive input, because while dealing with internal resorption, it's sure that we cannot enlarge the canal, we should not shape the canal, and ultrasonic might not be enough to remove all the cellular component, the clastic cellular component that's digesting the dentine. So I'm very, very fanatic of the single endodontic session, but in those cases where I have doubts about the removal, the total removal, I would recommend the calcium hydroxide as an intermediate session. And I think that you agree with me about it.
Yes, I thank you, Dr. Edmond. I totally agree with you. Nowadays, I feel like clinicians are more aggressive with single visit treatment, which I do a lot of times in my office. But the problem is with the resorption that it can be unpredictable. And if you leave plastic tissue behind, you can later on be faced with a more challenging situation where you get a combined defect, internal and external. So yes, I would still go for calcium hydroxide with internal resorption, despite the presence of all modes of activation and different kinds of file systems that are more adaptive to the shape or size of canals. But I agree with you, not all canals walls are touched with our instrumentation and our irrigation, and I would feel more confident using calcium hydroxide.
Of course, it will be a plus. It will give a positive plus. Number two, I really like the presentation about the ICR. I mean the invasive cervical resorptions, and I'd like to emphasize the issue about the use of the CBCT, because prior to any kind of treatment, even conservative non-surgical treatment, or much more with the surgical treatment, as you mentioned, the CBCT is a necessity in those lesions. Because we need to see, we need to really locate the lesion, because sometimes, most of the times, the PA would never be enough. And I don't like surprises during my surgery. So to really control everything, I'd like to have the CBCT because it will help me locate whether it is especially buccal or lingual. Because I've treated some ICR with a lingual flap because the lesion was on the lingual aspect. So you don't need to go buccally where you have a lingual. So for me, CBCT is really mandatory in those cases. And I'd like also maybe to emphasize the issue about the differential diagnosis between the internal and external resorption. It was so beautiful and so nicely presented on the clinical case, but I'm sure that because of the time frame, you missed maybe on purpose the differential diagnosis regarding the radiographic aspect, because it's really very interesting to see on the clinical case that you showed that the canal was intact. The anatomy from the canal aspect was intact, and the resorption was superimposed, leaving the canal totally without any modification, without any resorption. Now, coming to the MTA use, I maybe would not recommend it for the anterior teeth at least, because even if you are using the white MTA, it will cause a slight discoloration. And I have the experience clinical cases because I did not have at that time the bioceramics, and the white MTA gave me a negative result regarding the discoloration. Well, it maintains the tooth in place, but the discoloration was unpleasant for the patient, and we had to make a crown and try to cover it. And I think that the GI, the glass ionomer, can be used in a sandwich technique and can be layered up with the composite, and we can have a nice, very nice outcome and aesthetic result. But overall, the presentation was really excellent. You're a brilliant guy, and I'm very thankful for you for this kind presentation. And I think also that you are in the early morning now at your time, no, in Minnesota.
It's noon time now.
Noon time. Good. We did not wake you up.
No.
Thank you very much for your time and for the quality of the presentation.
Thank you for being with us.
My pleasure and my honor too.
Thank you, Professor Khaled, Dr. Khaled B.
Thank you, Dr. Omar and all panelists and Dr. Tony for this presentation. Actually, I have some sort of inquiries more than a question regarding the cases that has replacement resorption or ankylosis. And if the cases was treated and asymptomatic, but we still have the periapical radiograph shows some sort of resorption, what would be the endodontic diagnostic term for periapical diagnosis for this case?
So with the periapical diagnosis, unfortunately, the list of diagnostic terminology by the AAE, it's not covering or encompassing the whole thing, because at this point we cannot really call it condensing osteitis, because it's the patient's own bone that is replacing the tooth structure, and not necessarily bone that's being more dense at the apical part of the tooth. But from a diagnostic standpoint, I would call it asymptomatic apical periodontitis, and that's because usually with these cases with percussion testing, the patient is asymptomatic, and you can just feel the metallic thud of the percussion. But with the advancement of the resorptive process, the more and more you see tooth structure disappearing and more bone you have it in there, I would tend more to call it asymptomatic apical periodontitis.
Yeah, actually, I agree with you. There are still some limitations with the AE guideline for diagnostic term, and it really doesn't cover most of the cases that we want to dissect, like this case. And because of term of insurance and referral, and sometimes you need to put a diagnosis for these cases. So I don't think normal would be appropriate, even if it's asymptomatic or if it doesn't need a treatment. I would agree with you, maybe with asymptomatic apical periodontitis would be the more of appropriate term for such a case. And regarding the case that you and the ICR, which you treated surgically, what type of attachment do you expect between the periodontium, between the gingiva and the restorative materials?
So the reason why we use glass ionomer as a modified glass ionomer is through a periodontal literature guidance. They guided us to use this kind of material. What we're hoping for is periodontal ligament regeneration through the remnants of the interdental, the supracrestal fibers, and some gingival fibers after the repositioning of the flap. But if not, I'm just hoping for junctional epithelium at that point, something that would just eliminate the possibility of infection and maybe getting a pocket in the area.
Yeah. My last question is regarding most of the cases that comes from the orthodontist, and sometimes they have an external root resorption. Some of them sometimes needed the root canal for the sake of symptomatic irreversible pulpitis or necrosis or whatever reasons. What is the best protocol to manage this case? Would you treat it fully, or would you dress it with calcium hydroxide till the end of the treatment? As far as we might not expect exactly what would be when at the end of the resorption exactly, but what is the protocol for this?
So I would recommend calcium hydroxide intracanal medication for any external resorption case. And that's because I'm not sure if all the clastic tissue was removed. And also, I'm not sure if my irrigation protocol and instrumentation, I was able to remove everything. So I would go with calcium hydroxide for 2 to 4 weeks. If I decide to go to 4, at least I'd bring the patient back to replace it once, because the endodontic literature has shown us that the peak of the action of calcium hydroxide is 2 weeks, so we don't want to leave it more than that. But I totally agree with you, Dr. Khaled, that calcium hydroxide will be the way to go, at least knowing deep inside that we try to do our best to save this tooth for the patient. And if not, I'm setting the expectation for the patient that if it fails, maybe down the road, we'll need surgery.
Okay, thank you very much, Salah, for the excellent presentation. And I will leave the microphone with Dr. Hassan.
Thank you. This is my turn to ask.
Thank you.
I kept myself to the end. So to give you a chance. Actually, it's not a question. It is. I would like to elaborate and just to clear a little point that you mentioned, which is very, very valuable to our audience, and this word to our audience. If you ask your student, any one of our professors, how many type of percussion that we do in our diagnosis, and I'm sorry to say 100% will tell you it's 2 types, vertical and horizontal percussion. But as a matter of fact, Dr. Omar today mentioned a 3rd type of percussion, which is a very crucial, very important, very helpful in diagnosis a lot of cases. And he mentioned under the name of metallic percussion. And we call it sometimes the sound percussion. The sound percussion is the 3rd type of percussion that you do not rely on the patient's answer, you rely on your ear. When you hear a copper sound, that's very important to diagnose 3 important cases. Number 1 is ankylosis. You will hear the sound percussion. And if you hear it once, you will never forget it. And number 2 is a resorption, as Dr. Omar mentioned. And number 3 is the intrusion. Also, it's a very, very useful way to diagnose in the intrusion. as you notice in the 3 type of this, there is no BDL. And that's why you will hear the sound percussion. So thanks for mentioning this, because will help our young dentists to assure their prognosis, either in case of resorption or intrusion or the ankylosis. And the second point that I would like also to elaborate on, that as you mentioned, is there is misconception, because most of people, when they diagnose a case as a resorption, they consider it dead, or they consider it unlive, or they consider it it's inactive. No, resorption is actually a vital process. It's a vital process. There is a teeth, there is a cells inside eating, and you have to stop it one way or another, as Dr. Omar mentioned, by either you stop this action of clastic activity of these cells, or to remove it as well. Otherwise, you will be surprised when the patient escape and they come back and you'll find the whole tooth is gone, which is require us to be very alert and very speedy. Personally, Tony, do we have any time to entertain some question from our audience?
Yes, indeed. And I think Dr. Ahmed will take care of that.
Okay, that's great. Yeah, Dr. Ahmed, it's your turn.
No, I have one question here, and I invite all participants, if they have question, to write it in the chat. It's a question about the restoration in root resorption. Is what about dual cure bioceramic, like thermal BT?
Yeah. So with the restoration for invasive cervical resorption, again, the reason why I use glass ionomer, resin modified glass ionomer, because we have a lot of periodontal literature to support us do that. But with dual cured bioceramics, still I don't have enough evidence for me to be convinced to shift from glass ionomer or resin modified glass ionomer to dual cured bioceramics, especially that with dual cured bioceramics, we're not sure about the behavior of the material itself, because it has a lot of resin in it. The interaction between resin and bioceramics, it's not fully understandable yet. So I will stick with glass ionomer and resin modified glass ionomer for now. See how things go in the future. But honestly, I don't know to answer if it's going to be promising or not.
Okay, we have another question. It's a little bit long. He asks about, do we always need to treat the tooth endodontically when it has an internal root resorption? My understanding is root canal treatment is needed when internal root resorption is diagnosed. But I found this case and it says the internal root resorption healed. He is sending a connection to an article about healed root canal internal resorption. Do you have an explanation for cases where internal root resorption heals and stops progressing?
I wouldn't call it healed. In my prerogative, if I see internal root resorption, I treat the tooth endodontically, no matter what. I go for root canal treatment. It might not be, it can be a little bit tricky, and it's rather going to be the exception rather than the rule to follow. So if you see it healed, probably it's not healed by laying down natural tooth structure. It could be that it's just mineralization or deposits of mineralization by the tissues in the area, and or remnants of vital pulp inside the tooth. But to see internal root resorption and monitor, if it's not surface resorption, I will go for treatment right away.
Okay, another question, and actually I was thinking about asking you that, but for time reasons I didn't. Do you notice that with internal resorption that the tooth or the canal underneath is having some calcification? sometimes.
Yes,
Yes.
that's totally true. As we mentioned earlier, the necrotic pulp is above the defect, and then you need to have source of cells apical to the defect. And with that vital pulp, it's not completely healthy. It has some sort of inflammation, so you can expect any type of response, whether an inflammation or a protective mechanism of laying down a tertiary dentin, or any type of response you can expect.
This is the end of the questions. Dr.
Okay,
Shihabuddin
okay.
Saber says hello to you.
Hello, Dr. Shihab. Miss you
Okay,
a
Dr.
lot.
Hassan.
Okay.
Okay, Dr. Hassan, take the lead.
I think we have to conclude this excellent presentation. It was.
May I add something, please, before concluding?
Sure, please.
Okay. Sorry to interrupt, but I really would like, as a return gift for all the participants who are with us today, if they have a question about resorption and orthodontics, because this is the main cause for resorptions, for external resorptions, I would like to give them the return gift by a publication written by our guru in endodontics, Professor Jim Gutman with Hamilton. They published in the International Endodontic Journal in 1999 about the resorptions, external resorptions, especially due to orthodontics. And they would have really fantastic answers about the resorptions involving vital teeth, non-vital teeth, treated teeth, surgical treated teeth. Shall we stop? Shall we delay? Really, you will have valuable questions. There are 7 questions inside, which are really fantastic, and the answers are really and truly very, very helpful. So
maybe Tony can put it in the journal. Would be nice.
Okay. So for those who heard it, it's Hamilton and Gutman, IEJ 1999. It's endo-ortho relationship. It's really fantastic paper.
Excellent. At the end, I would like to
endorse this paper too, Dr. Edmond. It's a great article.
Yeah. I would like to thank everybody participate today in this webinar. I would like to thank Tony for an excellent organization, and he's always collected the nice people. Thanks, and thanks for the audience, the great audience that we have today with this large amount of names that I've seen. Some of them are very close friends. And thanks for Dr. Omar for enlightening us with this, I would say, critical topic, because I always have a lot of questions after I give this lecture. I always have a lot of questions because it's a delicate, and as Dr. Hashim said, it's contradicting sometimes. Thank you very much, and wish to see you soon in another webbing seminar number 8. Thank you, Tony.
Thank you. Thank you very much.
Thank you.